Hello and welcome. Today we're diving deep into a serious and potentially life-threatening condition affecting the lungs: air embolism, specifically with pulmonary involvement. This is a condition where air bubbles enter the venous system and travel to the pulmonary arteries, causing significant respiratory distress and potentially leading to death. Let's explore what causes it, how it affects the body, and what can be done. Air embolism, in general, doesn't arise spontaneously. It's almost always a consequence of a medical procedure or trauma. Common causes include complications during surgery, particularly procedures involving the head, neck, or chest, where large veins are exposed. Central venous catheter placement or removal, especially if performed incorrectly, can also introduce air. Barotrauma, occurring during scuba diving or mechanical ventilation, is another possible cause, forcing air into the bloodstream. In rare instances, forceful coughing or even blowing the nose very hard can, theoretically, introduce small amounts of air, though this is exceptionally uncommon to result in significant air embolism. Finally, certain medical procedures performed during pregnancy, like therapeutic abortions, are known causes of air embolism. The pathophysiology of pulmonary air embolism is directly related to the size and quantity of air bubbles introduced into the venous circulation. Once air enters a vein, it travels towards the heart and then into the pulmonary artery. These air bubbles, acting as emboli, obstruct blood flow to the lungs. This obstruction leads to several critical problems. First, it increases pulmonary artery pressure, making it harder for the right ventricle of the heart to pump blood. Second, the obstruction causes a ventilation-perfusion mismatch, meaning some parts of the lung are ventilated, but not perfused with blood, and vice versa. This reduces the amount of oxygen that can be absorbed into the bloodstream. Severe air embolism can lead to right heart failure, systemic hypotension, and ultimately, cardiac arrest. Furthermore, air bubbles can trigger inflammatory responses and endothelial damage, exacerbating the situation. Accurate data on the precise incidence of pulmonary air embolism is difficult to obtain, as it often goes undiagnosed or is misattributed to other causes, particularly in the context of critical care settings. It's considered a rare complication of the procedures described earlier. Certain surgical specialties, such as neurosurgery and cardiovascular surgery, are known to have a slightly higher risk. The risk is also increased in patients undergoing procedures with steep Trendelenburg positioning, where the head is lower than the heart, increasing the risk of air entry into open venous structures. Factors such as patient age, underlying cardiovascular conditions, and the specific technique used during medical procedures can also influence the likelihood of developing an air embolism. The signs and symptoms of pulmonary air embolism can vary depending on the amount of air entering the circulation and the speed at which it enters. In mild cases, a patient may experience sudden onset of shortness of breath, chest pain that might be described as sharp or stabbing, and a persistent cough. They might also be anxious or agitated. In more severe cases, symptoms escalate rapidly. The patient may experience a dramatic drop in blood pressure, leading to dizziness or loss of consciousness. A characteristic churning or splashing sound may be heard over the heart with a stethoscope. Cyanosis, a bluish discoloration of the skin, indicates a lack of oxygen in the blood. Neurological symptoms, such as seizures, confusion, or even stroke-like symptoms, can also occur if air bubbles travel to the brain through a paradoxical embolism, that is, crossing from the venous to the arterial side through a patent foramen ovale. Diagnosing pulmonary air embolism can be challenging, especially when symptoms are subtle or masked by other underlying conditions. The first step is often clinical suspicion, based on the patient's recent medical history, particularly any recent surgeries or procedures. Diagnostic tools include electrocardiography, which might show signs of right heart strain. Blood gas analysis can reveal hypoxemia, a low level of oxygen in the blood, and potentially hypercapnia, an elevated level of carbon dioxide. The most definitive diagnostic tool is imaging. A CT angiogram of the chest can often visualize air bubbles in the pulmonary arteries. Transesophageal echocardiography is another useful tool, allowing direct visualization of air in the heart chambers. However, these imaging modalities may miss smaller air emboli. In some cases, a diagnosis is only made at autopsy. Pulmonary air embolism isn't typically classified into distinct types, but rather by severity, volume of air involved, and the patient's response. Some sources refer to massive air embolism, which causes rapid cardiovascular collapse, versus less severe cases, where symptoms are more subtle and the body has some capacity to compensate. The duration of exposure, such as the period between exposure and treatment, also plays an important role in classifying the embolism for treatment approaches. It's best to think about it as a spectrum of illness, ranging from mild and easily managed to severe and rapidly fatal. The treatment of pulmonary air embolism is focused on supporting the patient's vital functions and eliminating the air from the circulation. Immediate steps include placing the patient in the Trendelenburg position, lying down with the head lower than the feet, and turning them to the left lateral decubitus position. This maneuver helps trap the air bubbles in the right atrium of the heart, preventing them from entering the pulmonary artery. 100% oxygen should be administered to help reduce the size of the air bubbles by increasing the oxygen gradient. If the patient is hypotensive, intravenous fluids and vasopressors are administered to maintain blood pressure. In severe cases, cardiopulmonary resuscitation may be necessary. In rare cases, where the embolism is massive and life-threatening, surgical removal of air from the heart or hyperbaric oxygen therapy may be considered. Hyperbaric oxygen therapy increases the pressure around the patient, which helps to dissolve the air bubbles into the bloodstream. Prevention is the cornerstone of managing pulmonary air embolism. Careful surgical technique, especially during procedures involving the head, neck, and chest, is essential. Central venous catheter placement and removal should be performed with the patient in a flat or Trendelenburg position, and careful attention should be paid to prevent air from entering the catheter. During mechanical ventilation, pressures should be carefully managed to avoid barotrauma. Scuba divers should follow established safety protocols to prevent decompression sickness, which can lead to air embolism. Education of medical personnel about the risk factors, signs, and symptoms of air embolism is also crucial for early recognition and prompt treatment. The prognosis for pulmonary air embolism depends heavily on the severity of the embolism, the speed of diagnosis, and the promptness of treatment. Mild cases, if recognized and treated quickly, often have a good prognosis with full recovery. However, severe air embolism can be fatal. Even with aggressive treatment, long-term complications can include residual lung damage or neurological deficits, especially if there was a delay in treatment. Recent research focuses on improving early detection methods, such as developing more sensitive imaging techniques. Other research explores the potential role of pharmacological agents to reduce the inflammatory response associated with air embolism and improve outcomes. Additionally, advancements in hyperbaric oxygen therapy protocols are being investigated to optimize its effectiveness in treating severe cases.